Thank you so much, Dr. Abdallah, for your invitation. Professor Rosano, thank you for being in this meeting once again. I'd like to congratulate my dear friend and brother, Dr. Abdallah, despite of his birthday yesterday. He is busy with us, so happy birthday to you, and wish you all the best next year. My topic is not simple, it is big for the allocated time, but I will try to go fast through it. So I'm talking today about the critical role of anticoagulation therapy in the treatment of coronary artery disease and in the prevention of left ventricular thrombus. And we know that coronary artery disease basically is due to blockage of the coronary arteries, and left ventricular thrombus is a clot in the left ventricle. So the role of anticoagulation here is very important in one side to treat coronary artery disease, and from the other side to prevent blood clot or LV thrombus and consequently reduce heart attack and stroke. So we are trying to explore the recent guidelines for the use of anticoagulation, whether vitamin K antagonists like warfarin or the novel NOAC, like rivaroxaban and apixaban, and see what the guidelines will tell us to see what is the benefit of anticoagulation versus the risk. So the guidelines, for acute coronary syndrome, the latest one is the 2023 European Society of Cardiology, and I'm sure there will be some overlap with the slides Dr. Magdi showed us now, but we'll try to go quickly over that, and also I will focus on the medication that is available in UAE here for the sake of time. So the guidelines regarding the antiplatelet, aspirin has to be given in a loading dose of 150 to 300, followed by 75 to 100 milligram orally, or if the patient cannot take oral, then you can give 75 to 250 IV. Clopidogrel, as we all do, we give a loading dose of 300, followed by 75 milligram once a day. And for ticagrelor, we give loading dose of 180 milligram orally, followed by 90 BID. In all the three, there is no specific dose adjustment required for patients with CKD. When it comes to GB2B3A receptor inhibitors, we have here tirofiban. The bolus should be given by 25 microgram per kg IV over 3 minutes, followed by 0.15 microgram per kg per minute for up to 18 hours. If there is some renal impairment, then adjustment has to be done accordingly. What about anticoagulant? Unfractionated heparin. The initial dose should be a bolus of 70 to 100 units per kg, followed by IV infusion for a BTT of 60 to 70. If we do PCI, we go 70 to 100 units per kg bolus, and then we adjust according to the ACT, as we do routinely in the CAD lab. If enoxaparin is used, the initial treatment in ACS should be 1 milligram per kg BD, sub-Q for at least 2 days, followed by sub-Q daily until clinical stabilization. During PCI, if enoxaparin has been used before, then it should be given according to the time of the sub-Q injection prior to the PCI. So if it is less than 8 hours, there is no need, but if it is more, then another bolus should be given of 0.3 milligram per kg. This is the diagram explaining or showing the mechanism of action for antiplatelet antithrombotic. I'm sure you are all aware of. This figure shows the recommended antithrombotic therapy regime in ACS for patients who do not need or no indication for anticoagulation. You can see here, the guideline divide here to STEMI and non-STEMI. So if the patient has a STEMI and going for primary PCI, unfractionated heparin has class 1, then enoxaparin and the rest is lower in the level of evidence. And then after that, aspirin should be given as a pre-treatment. Ticagrelor, that's what we give here, should be given unless it is not available or there is contraindication, then clopidogrel should be given. And then this should be continued, aspirin and B2Y12 inhibitor, at least for 12 months, and then maybe go for monotherapy after that if the patient is not high bleeding risk. If the patient has non-STEMI and the angiography is done less than 24 hours, and again heparin is given, followed by B2Y12 inhibitors if primary PCI is done. The class here is 2B, and then if you proceed to PCI, then the ticagrelor or prasugrel should be given, and the evidence is class 2A, and again, the aspirin and, or the dual antiplatelet should be given for at least 1 year. This is the slide Professor Magdi showed, the antiplatelet, the alternative antiplatelet strategy to reduce bleeding. This is the abbreviated dual antiplatelet versus the de-escalation strategy, and I will skip that because Dr. Magdi elegantly described that very well. So these are the level of evidence here. The aspirin has class 1A. The B2Y12 receptor inhibitors recommendation is 1A. BBI, particularly in patients at high risk of bleeding, 1A. And ticagrelor, 1B. Then the clopidogrel, the loading dose is 1C. Patient who present with acute coronary syndrome and they are going for bypass surgery should stop the dual antiplatelet for the purpose of the surgery. However, after surgery, it should be resumed again for 12 hours. This is very important. Now, pre-treatment with B2Y12 receptor inhibitor may be considered in patients undergoing primary PCI. This is 2B. Patients who have non-STEMI and who are not expected to undergo an early invasive strategy and do have high bleeding risk is 2BC. So you should not, you can, skip that. Now, what about anticoagulation? Parenteral anticoagulation is recommended in all patients with acute coronary syndrome at the time of diagnosis with a strong level 1A. The routine use of unfractionated heparin bolus is recommended in patients undergoing PCI. IV enoxaparin at the time of PCI should be considered in patients treated with subcutaneous enoxaparin. Discontinuation of parenteral anticoagulation should be considered immediately after an invasive procedure. I'll skip that. I want to focus more on combining the antiplatelet and oral anticoagulation, which is actually a challenging issue, giving a triple therapy. So as a default, the strategy for patients with AFib and chest VASC score more than 1 or in men or 2 or more in women should be having triple therapy for at least 1 week following acute coronary syndrome event. Dual antithrombotic therapy using NOAC at the recommended dose and stroke prevention, and a single oral antiplatelet, preferably clopidogrel, for up to 12 months. This is class 1A. During PCI, heparin should be recommended, and if the patient is on NOAC or if the patient is on warfarin, we should keep the warfarin. If the warfarin, if the INR is less than 2.5. What about rivaroxaban? Rivaroxaban should be used and concerned about high bleeding risk prevail over ischemic stroke in a lower dose, 50 milligram once a day. And this is that that the standard dose is 20, and this has class 2B indication. Dabigatran should be also used at a lower dose, 10 milligram BID. Not the full dose of 150 milligram if the patient has high risk of bleeding. Patient requiring oral anticoagulant then the withdrawal of antiplatelet at 6 months and the continued oral anticoagulant may be considered, and the use of ticagrelor as a part of triple antithrombotic therapy is not recommended. This is 3C, which means it's harmful. This is regarding the evidence for the de-escalation antithrombotic therapy. You can skip that for the, yeah. Now, what are the patients that we need to prolong the antithrombotic therapy? Discontinuation of the antiplatelet in patients treated with oral anticoagulant is recommended after 12 months. This is class 1B. Adding a second antithrombotic to aspirin extend the long-term secondary prevention should be considered in patients with high ischemic. Strategies for reducing bleeding risk due to PCI. Patients who have anticoagulation doses adjusted to body weight and renal function. Radial approach should be the standard vascular access. BBI should be considered patients who have high risk of bleeding. This diagram shows the strategy of using antithrombotic in patients with acute coronary syndrome and the atrial fibrillation. So if the patient, the default strategy, if the patient has indication for oral anticoagulation, triple antithrombotic therapy should be used at least for 1 week. And then after that, dual antithrombotic should be used from 1 month to 6 months. And then after that, you can use oral anticoagulant with single antiplatelet. If the patient has the strategy to reduce ischemic risk, if the patient has high ischemic risk, then this triple therapy should be used up to 1 month, followed by the dual antithrombotic, which is oral anticoagulant and single antiplatelet. Then after that, after 12 months, oral anticoagulant monotherapy as well. This requires frequent laboratory monitoring, patient education, and individual dosing. And with advances in laboratory techniques and targeted therapy and collaborative research, we hope that this will improve and we will be able to prevent ischemic events and reduce bleeding risk in the future. And the next section of my presentation will be over the latest guideline for chronic coronary artery disease. And I am using here the American Heart Association guidelines, which was published earlier this year. And they are targeting these patients who are discharged after acute coronary syndrome, patients with left ventricular systolic dysfunction, stable angina, angina symptoms secondary to spasm or microvascular angina, and patients who are routinely diagnosed by a screening study like stress test or CT angio. The problem is worldwide, and our area is not spared. It is very high in our area. So what the recommendation here? The recommendation is to use dual antiplatelet, aspirin and clopidogrel for 6 months post-PCI, followed by single antiplatelet. And this evidence is one. If patient has also drug-eluting stent and completed 1 to 3 months of dual antiplatelet, it's recommended to use a B2Y12 inhibitor monotherapy for at least 12 months. So patient with chronic coronary disease and oral anticoagulation, what should be done? If the patient is going for elective PCI, those require oral anticoagulant therapy, then dual antiplatelet should be given for 1 up to 4 weeks, followed by clopidogrel alone for 6 months. If the patient is going for PCI and he has high thrombotic risk and low risk of bleeding, then aspirin and clopidogrel should be given for 1 month, and this is class 2A. If the patient has low anti-atherothrombotic risk, then you can discontinue aspirin and continue DOAC monotherapy for 1 year after PCI to reduce bleeding risk, class 2B. If there is no acute indication or for concomitant antiplatelet, then consider DOAC monotherapy. Antiplatelet therapy and low-dose DOAC, patient with CCD without indication for DOAC or DAB, this high risk for recurrent ischemic event and low moderate risk, add low dose of renal ropicetin 2.5 twice a day to an aspirin 81 milligram for a reasonable long-term reduction of MACE class 2A. And for all these patients who have high risk, DBI should be considered. All right, I just have, I need 2 minutes, yes. Thank you. Let me just go over the left ventricular thrombus quickly, just a couple of slides. We know that if there is acute coronary syndrome, left ventricular region of motion abnormality, akinesis, dyskinesis will induce stasis with hypercoagulability and subendocardial injury, left ventricular thrombus will form. This can be diagnosed easily by echo in most of the cases, either with or without contrast. If it's not clear enough, then MRI is very sensitive for diagnosis of Eldeeb thrombus. What is the management here? Anticoagulation should be given for 3 to 6 months, depending on the risk of bleeding. Then recurrent repeat left ventricular imaging by means of echo or MRI. And if the patient has left ventricular aneurysm, then we continue indefinitely anticoagulant and reevaluate every 3 to 6 months. If the patient has no aneurysm and has low bleeding risk, then anticoagulant should be continued indefinitely with reevaluation. But if the patient has high bleeding risk, then we may stop the anticoagulant and reevaluate. So this is the recommendation for treating left ventricular thrombus. So in brief, let me go for the conclusion. Coronary artery disease is a significant contributor to ischemic event and major independent risk factors for morbidity and mortality. DOAC reduce atherothrombosis by either blocking thrombin directly or by blocking factor 10A. Patients with a stable coronary artery disease without AFib had better cardiovascular outcome with addition to rivaroxaban along with aspirin, although the major adverse bleeding risk was higher, while patients with AFib had non-inferior cardiovascular outcome and decrease in major bleeding when using Rivan. But just one slide. Okay, so patients with acute coronary syndrome had inconsistent improvement in MACE events, but a higher major bleeding risk when DOAC was added to DAPT. The substitution of DOAC in lieu of aspirin in these patients has similar bleeding risk profile and a similar instance of cardiovascular event. However, larger and more adequately powered studies are needed to determine efficacy of this regime. In patients with AFib and ACS or PCI, DOAC along with B2Y12 inhibitor and similar rates of MACE compared to triple therapy with VKA, B2Y12 inhibitor, and aspirin. However, there was general trend toward a better bleeding risk profile. Finally, there should be an emphasis on estimating the bleeding risk profile of the patient. Shared decision-making between the provider and the patient is immensely important as the addition of anticoagulation and antiplatelet agent in combination increase bleeding risk. Thank you so much.